Okay, mostly this is for you, not for me. So if you've got questions or comments, and I've got a couple of questions for you as well. Do you have anything you want to talk about? Anything left unsaid, undone in the class or on previous Zoom sessions? How's that, Dylan?
Hi, Jim.
No, this is going to be a shorty. I've got nothing else to teach you. You sucked me dry. Seriously, got nothing to ask. Okay.
In terms of treatment, how do you fit this stuff in with other techniques? Say, for example, soft tissue stuff or needling.
Yeah, a lot of people use needling with manipulation and mobilization. I think a lot of it depends on how you're using needling. I actually stopped using needling for as anything other than a muscle stim technique to get inhibited muscles working. Otherwise, I stopped using it because the two overlap. The manual therapy and needling therapy really do overlap, and I think what you can do is use needling. The only thing is that manual therapy, particularly manipulative therapy, probably almost certainly has a mechanical effect as well as a neurophysiological one. You can feel the change in the end feel and everything else, although that could still be neurophysiological. But I'm sure it has a mechanical effect as well as a neurophysiological. Needling pretty much is a neurophysiological effect. So if either of them is going to last, it should be the manipulative technique. So if I can manipulate it, I will. And if manipulation works, I'm pretty much done with it. That's it, I'm done. I don't use needling under those circumstances. But a lot of people do use needling, and it's usually when manipulative therapy hasn't worked as fully as you would like. And I think that may be an issue with judgment as well. I didn't talk to you much about this, but I did. It's mostly spinal where you need to be a bit careful with this. Is I don't think you can over manipulate if you do it right. You can't do damage with manipulation if you're doing it right. But it gets a bit counterproductive. So what I found in the spine is, yeah, I used to see them 2 or 3 times a week, mostly depending on how busy I was, in all honesty. I'd see them 3 times a week, especially things that were being paid for like compensation or ICBC, where there was no real limit on it. If I wasn't very busy, I'd see them 3 times a week. If I was busy, they'd be seen twice a week. But either way, if they needed manipulation, I would do it and then do it again the next time they came in, then look at them again and do it again. So these people were getting treated 2 or 3 times a week with manipulative therapy. When I started doing more consults rather than a general practice, and I was asked to keep on treating them because for one reason or another, I'd only see them once a week anyway. And what I found was that if I treated them once a week and went back, they were much better than when I saw them a couple of days afterwards, as I was doing in the clinic. So that if I manipulated them on Monday and I saw them again on Wednesday, they would sort of be much better immediately after the manipulation. Wednesday, they'd drop back a bit, so you'd hit them again. So I think what I wasn't doing was giving them a chance to recover. So I've come to the conclusion that the best thing you can do now is, certainly with spinal manipulation, manipulate them and probably not manipulate them again for about a week. If they need it, then do it again, rather than every 2 or 3 days. My experience with peripheral is obviously not as big as it is with spinal. Most of your patients, I would think, are spinal, aren't they? Rather than peripheral. So I'm not prepared to say that about peripheral manipulation, but try it and see what happens.
Jim, like when you say you manipulate it, like you manipulated the exact same joint again within the 3 days? Yeah, okay.
Yeah, they'd get better, drop back a bit, you go in, find the end feel and everything else, hit it again. But I don't think I was allowing enough time for the full neurophysiological effect to occur from the manipulation. Otherwise, as I said, basically I was using needling to stimulate things like multifidus or supraspinatus or the rotator cuff muscles, where you really want to get down and make sure that muscle is actually contracting and not the crap over the top of it. Yeah. But I think they're overlapping modalities, really. I just don't think that needling, it's certainly not as efficient. I manipulate somebody, you get an immediate mechanical effect from it, and you can see what's happening. Needling takes longer to see that effect, and on average anyway, and I don't think it lasts as long. Could be I don't do needling that well though. But do you find that? Do you find that they pretty much do the same thing? You certainly treat the same patients with them, didn't you? The same conditions. So the question is, why would you pick one over the other? Your answer to that, if you've been needling for a while, is because you're more familiar with needling than you are with manipulation, and you're better at it. You know, that's the obvious answer, but it's probably not the best one. So do it. I mean, basically, there's no reason why you can't do both. None at all.
Yes, in the same session, then, would you only manipulate it once, or would you do it?
No, I'd manipulate it until it stopped needing it. There's a lot of rules that you learn that don't hold up. I remember doing exams in the US. No, it wasn't, it was in Canada. And I was co-examining, and it was it's a level 4, so they was doing manipulation. Anyway, he got the patient down, I think it was the neck, and he hit it once and it didn't go, so he hit it again. And he left and we discussed it. And the person I was working with, extremely experienced and very good therapist. He said, well, that's a foul. So I said, why's that? He said, well, he hit it twice without really looking. I said, you hit it twice without looking. I hit it twice without looking under those circumstances. Everybody does. Everybody, if you don't go, you do it again. Yeah, everybody does that. So what's your issue? Well, he shouldn't have done it. Why not? Because we told him not to. So this is do as I say, not as I do. We had a bit of a row about it in the end. So a lot of these rules are there for, I really don't know why, in all honesty. I did I did exactly the same thing with, I was watching Syriacs. We used to go to his clinic once a week at the school I was a student in. And we'd all stand around the walls and he'll be in there and he'd manipulate the patient with this stuff. So one day he looks up and said, you come and do it. And it was a neck. So really, this, I don't know if you've ever seen a Syriac technique, but you put your feet against the legs of the bed and you push back with your legs, and it's 200-pound attraction there going through the patient's neck. You got it there and you turn it, hit it and let it go, clear them up. So I did it, and nothing happened. I did it again. He looked at me and he said, okay, he said, if you think you know better than I do, you just carry on doing what you're doing and we'll see how it all works out, won't we? All that shit. Sarcastic bugger when he wanted to be. So he's dead now, he's got his. Yeah, no reason not to do it twice. And you've got to remember that you're learning, and it's going to be a while before you can do these techniques without a lot of thought. And some of these techniques are not easy to do, and the patients are not easy neither. So I wouldn't get too discouraged if this thing isn't right there, right when you want to do it. Yeah, and there's no reason why you can't do it a second time at all. Anything else? Sentil, do you have anything?
Yes, Jim. Last week I saw a like probably like around 15 years old girl with abducted ulna, and I think like she's a gymnastics, and she was doing a flip, and then afterwards she having a severe pain in the medial elbow. And I checked, there is increased carrying angle, and I felt it's a abducted ulna, and just checked the valgus stress and everything. So everything was okay. And even I confirmed with my another colleague who do manipulation. So he said like, yeah, it's for sure, it's abducted ulna. So, but she is having a flexion limitation too. So the presentation, it's so when we see abductor ulna, so one of the essential illness scripts, if you want to just get it, so it will be like limited range of motion in flexion and extension too.
AB ducted, yes.
Yeah,
Yeah.
abducted.
Yeah, that's what it limits. It limits flexion and supination.
Yeah, the supination was okay. It's not like limited. So only the flexion is limited for that girl.
Well, you've got to feel the end fill. When you say it's not limited, if you actually took a goniometer to it, you may not measure the limitation, but the end fill will tell you that there's one there.
Yeah.
If you do the combined movements, this is where you mostly see it. So if you're doing flexion and pronation, flexion and supination, that's going to show you a bigger limitation than either of the two by themselves will do, almost certainly.
Yeah, flexion and with supination, the one I think it's limited, and she complains of pain too.
Yeah. The only thing with kids is a growth plate. But given that she's a gymnast, they've already screwed that up probably.
Yeah, she has a lot of injuries. She usually come regularly to see my colleague for one after the other. She get manipulated and needled, so she used to it.
So you manipulated her. What was the result immediately afterwards?
There is a definitely for sure that is improve in the range of motion, but the pain was still there. So I just asked her to just come back. And again, later, I just did again one more session for the following week. And it was a lot better.
Okay. Did she have any pain on extension at all?
No, she don't have any. Specifically, she complains pain only during the flexion, especially with supination.
Okay, because what can happen, of course, is with that type of trauma is you can have a traumatic arthritis there as well. Okay. So you'll clear up the biomechanical dysfunction, and then you're left with the arthritis.
Okay.
Yeah. But you should be seeing when you manipulate something, the patient's response should be immediate, a beneficial response as well. You shouldn't have to manipulate them and send them away and then see them again in a week. You should know that manipulation worked when you did it, both in the patient's response and the range of motion testing. Now, actually, it's possible that your manipulation may actually make them sore, but that comes on later on. And that's generally because there's a bit of a microtraumatic arthritis in there that you may have caused with a manipulation. But the immediate response should be beneficial.
Okay.
And that's another reason not to see them too quickly, neither, after you've done it. Anyway, once, if you do see them, they come in next time and say it's a bit sore, and you look at it and all your biomechanics are good, but the elbow's sore, just like do anti-inflammatory treatments and bullshit like that, and then tell them you're going to wait because it's going to go by itself, and then watch what happens. Right, that's usually what it is. If you noticed during the class, and I forget who it was now, had back pain. And it followed an ankle manipulation. When he pulled the tractor on, he had fairly severe thoracic pain. Did you notice that at all? So he asked me to look at it and manipulate. I said, no, just leave it. We'll look at it again tomorrow and see what it's like tomorrow. And he came in the next day and it's pretty much better by itself. And the problem is jumping in at that point, it's flared up. So basically, it's probably not the best time to do it. Leave it for a bit, see what happens. Anytime you're in that sort of situation, it's unusual, where you can see them immediately, where you normally wouldn't see them for a few days, and it's not an urgent medical thing, but it's painful. Leave them till the next day. You know, do some anti-pain treatment if you like, but don't do anything to them. There's one or two things going to happen. It may get better, in which case you can take the kudos. No change may occur, or more likely, it's going to flare up when you do hit them, and then you can take the blame for that as well. So, if you can, just leave it for a day. And you will have that with patients. They'll come in and say, yeah, you tripped my back. Well, I was playing football yesterday. I went over on my ankle. Have a look at it, but I wouldn't mess with it too much. If it needs manipulating, leave it till the next treatment.
I have a question about the distraction manipulation. It's my the owner of like clinic I work at, he's an F camp, and he always says, I've heard say all the time to like lay down. He like recommends it to all the therapists at the clinic because it'll traction the nerve.
No, it won't.
Okay, I didn't think so.
No. if you think about it, that nerve has at least 80 or 90 degrees of straight leg raising before it starts to become tense.
Yeah, I've heard him tell it, and then I was just like doing like gentle distraction
I
on
know.
it.
This
He told me not.
was a story. This was a reason for a precaution to doing it 20 years ago, and it's probably still being propagated now, but it's absolutely stupid. I could do a straight leg raise, and that's what you're supposed to do, a straight leg raise, yeah?
Yeah.
To make sure it's okay. If you want to do that, do it. But a patient's walking around. You know, in all seriously, if you've got an adhesion, you're not going to walk properly. You're going to have pain in your leg. It's ridiculous. It's absolutely ridiculous in my mind. But if you really want to do a straight leg raise and then dorsiflexion on the knee, do so. The amount of distraction that is caused by that is minimal. Absolutely minimal. You're not going to tense the nerve up. Rebecca, have you got any questions for me?
I remember you showing us, and I couldn't find it on the USB. It was, I think it was like the metatarsal manipulation. If it was like, I can't remember exactly how it was, where it was like elevating like the end of it.
Yeah, that's the second. So if the second one, I suppose it can happen to the rest of them, but the second one's a key one.
Yeah.
The base will go up.
Yeah.
And the head will come down.
Yeah.
Yeah, that one I said you thrust here and lift at the other
You lift.
end.
Okay.
Because if you simply thrust it down, because it's such a plain joint, you're not going to get, like with this, for example, if I push this down, then everything's going to move down, but this is planar. So it's tend to do that rather than that. Or up rather. Then the lift sort of obviates that. There's no reason why you can't do it without the lift, and if that doesn't work, then do the lift.
Okay.
The thing with doing it every time you do it is you get practice at it.
Okay.
Zach, do you have anything other than the needling one?
I guess so. Like post once you do it, do you give them any, like the client or the patient, any feedback of things they shouldn't or should not do once you've manipulated?
But after a manipulation,
yeah.
I don't think it's any different from what you would tell them anyway. Almost everything you see in your clinic, unless you're doing a lot of sports or a lot of surgical stuff, almost everything you're seeing in your clinic are subluxations. So for me, the main reasons why you don't want them stressing the thing out is because you've got a stress fracture in there, or there's an arthritis in there that's taken a pounding. The subluxations, they don't bother me too much. They're either going to hold or they don't hold. If they're really unstable, they're not going to hold. In which case, you need to figure out some form, either a prosthetic, like an orthotic, or, excuse me, they're going to have to change entirely what they're doing. But there's no routine thing I give them. If they say their back, for example, I get this when I'm doing a lot of bending. What's your job? And if the job doesn't involve bending, they're doing something at home, chopping wood, I don't know, but they're doing something unusual at home, buy a brace, put it on when you're doing that, see if that works. Otherwise, what you got is stop doing that. That's really what it comes down to. It's a lot of, as I say, the subluxation is going to work, or it's going to hold, or it's not going to hold. And it's all very well to talk about stabilization exercise, whether you talk about the periphery or the spine. The fact of the matter is people won't do them. They won't do it. So you put in a lot of time and effort, and so do they, and a lot of money on their part. It's no skin off your nose. I mean, this is what you do all day long. So it doesn't matter to you if they keep coming for 12 treatments while you try to educate them on an exercise program. That's fine. This is what your job is. You're getting paid to do it. But for them, this is a lot of time, a lot of effort, and they're putting a fair amount of change into it as well. If they're not going to do this after you discharge them, what's the point? Yeah. So I don't do that. I'll show them what I think they should be doing, and then basically look at them doing it once more and say, okay, fine, doing fine. Give me a shout if you need to. Because I know damn well they're going to stop doing it. The time they will do it is when they're desperate, when this thing is like giving them trouble every week, or an athlete who's an idiot, and he won't stop doing what he's doing, or he can't because that's his job. Then those ones will probably do the exercise you want to give them, but the average person won't. I won't. Would you? And if you think about it, you're trying to engram a movement pattern here, and the best information is that's probably about 10,000 repetitions. Well, if you're doing 100 a day, every hour that you're awake, that's 100 a day, 10 every hour, 10-hour days. That's 100 a day. So that's 3 months of exercise, and over 300 days of exercising regularly every hour of your waking day. Who the hell is going to do that? And if you're trying to convince somebody I should do that, and they say, well, will it work? What's your answer? I don't know. But you don't know. Would you do it under those circumstances? And doing it 2 or 3 times a day ain't going to work.
Hurt myself, I do stuff to make it better. Seems to get better most of the time.
Sorry, say again.
When I get hurt, I do some exercise that I think will help, and everything seems to get better.
Sure. And how long do you keep doing it for?
Until I don't need to do them. Until
There you go. So we're talking about getting rid of the pain, which is absolutely fine. Exercises can be really good at that. But doing it for rehab, but you're doing neuro now. You're not doing orthopedics anymore. You're doing neuro. You know what neuro's like. That's why you're not doing it, because basically it goes on and on and on with very little gratifying results at the end of it. No, I haven't got a problem with exercises. I've got a problem with doing rehab or teaching a whole bunch of rehab to people who are simply not going to do it. So I think my job is to show them what they should be doing, make sure they can do it right, and then see them again when they need it and save their treatments up for the things I can do, like get rid of their pain. Kim, you got anything? Sorry.
No, I think I'm good. The AC joint though, the mechanics with that. So when somebody can't flex, it's because the AC joint is stuck where?
Well, this is what you need to be able to do. Yeah, we're talking about elevation now.
Yeah.
So you come up that way. What's moving is the scapula. All right, actually, it's on by the glenoid. So the scapula is moving as the arm's coming up.
Yeah.
So this is going down.
Okay.
It means that the clavicle has to be able to move forward, because the scapula is coming back on the clavicle. So if this is jammed backwards, then you can't elevate using the AC joint.
Okay, that makes sense. Yep.
By the way, this is not flexion. Everybody okay with that? It's elevation. This is flexion. And I still don't understand where the term scaption came from. Anybody help me there? This is flexion extension. It's a pure spin of the glenohumeral joint. Now, at the end of it, everything else is moving. So you get to that point. The AC joint now is doing exactly what it's doing when you come up that way. Yeah? Similarly with abduction, to get there, the AC joint has to be able to do the same thing. So the AC joint's fairly simple, really, providing you think about the scapula moving rather than the clavicle. Because there's no real rationale as to why the clavicle would go forward when my arm's moving backwards.
Okay.
Yeah.
Thanks.
Anything else, guys? Okay, I've got a couple of questions for you. This is the first time where I've made the videos and the Zoom sessions an integral part of the course. I've done it on other courses, but it's been an addition. This is also the first time I've taught this in a 2-day format rather than 2.5 days because of the videos and Zoom. So what I'd like is your comments on the videos and the Zoom sessions as separate so far at the moment. Did you find them useful or not?
Yes.
Or could you have done without them?
I thought it was useful because it broke things down a little bit. Like I weren't taking in so much as one at once. So you broke things down. So I just felt a little bit more prepared going into the courses. And then as somebody who always has to drive normally for courses and such, it was nice to limit that in clinic to, or like in person to smaller amount of times. So it was less time that I had to be away from home. So.
Okay. Rebecca?
Yeah, basically same as Kim said, because I have to drive as well. So having that kind of short amount of time, didn't have to take time off work and stuff. And yeah, it was nice kind of having that information going into the course as well.
Okay. Zach?
Yeah, I think the videos are helpful. I think it's just better on the Zoom things if they say what time it is.
Sorry, you're fading out.
Oh, because lots of times I can't tell when the Zoom meetings are.
They were on the same time every day.
I know, same time every day. But,
Every Sunday.
Every Sunday. I know, sometimes it's just awkward timing for me.
Well, I did ask the class what was best, and Sunday's usually the easiest for everybody. I know it's not going to be good for everybody, which is why I recorded them. Lost you again. You're muted. There you go.
The recordings are helpful because yeah, then you can go back and see what we missed or see what you're talking about. Especially if there's slides and stuff, and you can take your own notes. So I think it's helpful.
Good. Senthil?
Yeah, it's definitely helpful, Jim. So as it helps us to break down and we can just concentrate as you give some little homeworks. So definitely it will helpful.
Good. If I'm not going to ask you this now, but if you can think of any way that I can make them better, email me, would you? Unless you've got any ideas now, but it's a bit of a out of the blue. Would you do that? If you can think of any way to make that better, let me know. One of the reasons I do this is, a big one is actually to make you more familiar with the terminology and the concepts. So when we get to class, basically I can simply review them rather than teaching you. And that makes a huge difference. And I've noticed that in classes as well. It makes a big difference. What was interesting was, actually, I didn't get it from you. Rebecca, you said, Zach, would you have been, and Senthil actually, would you have been happy if that was a 2.5 day class rather than a 2 day?
The 2-day class will be okay because anyway, I'm driving all the way from Grand Prairie to there. So already, so that for traveling purpose, definitely 2-day class will be better.
Zach?
Or St. Albert, which is close.
Yes, you're easy. So what would you prefer, 2.5 or 2 days?
2 days is probably just easier because it's done quicker, but I guess the more practice is always better, in my opinion. The more.
Well, I'm not, this is my issue. I did a lot less theory in the class. So I think that half a day was me doing more theory. On the other hand, I did feel more rushed in 2 days than 2.5 days. And I just felt more rushed, and we was going much later than I normally do on those classes. We went to I think 4:30 each day, didn't we? Which is a lot longer than I normally do. So it was a squeeze. I've got to say it was a bit of a squeeze. But I'm hoping you didn't feel shortchanged by it. But if you can think of any way for me to improve the Zoom and the videos, then I can actually send you more videos. I'm just not sure how much more time you want to put in prior to a 2-day course. Well, what I can do is, it won't be targeted at peripheral, but I can send you videos on manual therapy, different topics, some of the webinars I've done if you haven't looked at them, and I can let you have those, and I can give you links to them if you want them. A lot of them are on YouTube, which you should have access to now, but there are others as well. So if you want them, just email me and I'll set up an emailing list and I'll start sending them out to you. Okay. All right, guys, it was nice seeing and meeting you all at the time, and hopefully see you on another one soon. Take care, everybody.
Thanks.
Thanks,
Jim.
Jim.
Thanks, Jim.
Bye.